name is Shirley Ann Higuchi, and I'm head of Legal and Regulatory Affairs of the Practice Organization. And I have the privilege of introducing the Alternative Practice Models program that we're about to start. As we mentioned earlier, we've been working a while on alternative practice models, and specifically with Kevin Ryan and the firm of Epstein Becker to identify models that will work for psychologists. And Kevin will describe the spectrum that is out there, the models that range from a smaller practice like co-location and referral that many of you are familiar with, up to the larger, more complex models like the Management Services Organization. Then after Kevin, who is an attorney, will speak, Drs Kanter and Bellwoar will describe an MSO that they're developing together and the transition from their smaller practice and how they sort of blossomed into a larger system over the last couple of years. Many of you will see how complex the MSO is, and I think it'll be somewhat overwhelming for many psychologists. So you might want to ask yourself, well, how is this relevant to me? And this is why we're here today. And we have a lot of psychologists that might say, hey, we don't have the resources and energy to do that, or we can't launch that. But hopefully after this discussion, you'll have a better familiarity of how you can. The MSO model is something that solo and small group practitioners can participate in. With a limited amount of effort, you can plug into resources and market power of a much larger entity, but keep the autonomy of your practice. Our spectrum of APMs is all models are run by psychologists. We really appreciate the value of psychologists and the role they play. And we encourage them to integrate with medicine, not by forming a single entity with medical professionals, but by forming a larger entity with behavioral health services, i.e. in working with hospitals, medical groups, insurers, et cetera. So I'd like to turn it now over to attorney Kevin Ryan.
As Shirley mentioned, there are a lot of alternative practice models that are available to behavioral health professionals and psychologists. And we've been working, our firm has been working with a lot of providers in other professions for years, helping set these up. And so what we're talking about today isn't something that's brand new or untested. The MSO model that Jeff and Vince are going to talk about in a little while is actually used in lots of different professions. I work with providers, physicians, optometrists, dentists, veterinary practices, laboratory practices, specific professionals such as anesthesiologists and emergency room physicians. Many of them work with management services organizations that are privately owned or publicly owned in many cases, and that then contract with professionals. And so what PO decided to do a couple years ago was they contacted our office and as well as several other attorneys, but decided to work with us in helping present these alternatives so that as integrated care becomes more common and more complex, that there are alternatives out there. And again, the purpose of these is for independent practitioners to have options other than just merger, which we will talk about at the very end. There are different types of alternative practice models. There's the referral network model, there's co-location, there's independent practice associations, and then this management services organization. And again, this is kind of a spectrum, and there are pieces that may overlap between many of them, but it gives you an idea of some of the options or some of the programs that you may hear about over the next couple of years, or that people or providers may come to you and offer for you to join. The risk and the integration, of course, increases with the complexity of the different options. So, I mean, there's very little risk with co-location or referral. As you start to get into an independent practice association, such as an IPA, obviously the integration and the risk goes up. With an MSO, the integration has to increase because, as Alan talked about this morning, there are antitrust considerations that have to be taken into consideration. So integration, either clinical or financial, has to occur in order for contracting to occur. And then finally, and this is at the very, very end, if you decide that you don't want to be independent, and merger actually requires the ultimate in integration and also carries with it an awful lot of risk that we'll talk about in just a few minutes. So let's talk about the referral network model first. It's something that anybody can really do when you think about ways to increase practice and integrating, have some type of alternative practice. It's just contracting with possible referral sources. This could be a primary care practice down the street or a hospital that needs behavioral health services. And you can find out what kind of services they want, where they could use the most help with, and just sign an agreement. Doesn't have to be a lengthy agreement. We talked about contracts or agreements. This isn't an employment agreement. It could just be a simple letter contract that talks about what services you'd provide to patients, what the payment would be for that, and some other specific requirements, maybe like if they refer a patient to you, you're going to get back to them within 24 hours or some other type of quality assurance type measures. But that kind of contract really has limited risk. It's probably something that's going to be very simple. It's something that's probably not going to obligate you to a lot of requirements to meet the referral agreement, and it's probably something that can be terminated very simply, usually with X number of days notice, probably somewhere between 2 weeks or 30 days. In this type of a relationship, you particularly if you're taking care of patients, you certainly don't want to abandon patients, so you'd want to give enough time for them to have the ability, if you're not going to continue it, to seek alternative care. Some referral networks are more complex. They may have you work with them on an electronic system. So if they refer to you, you may have input or access through a portal to almost like an employee portal or one of their provider portals to actually go in and put your notes into their system so that they can see that you've seen the patient and that communication can go between both parties. And there may even be some agreement between the parties that because they need this care, that they will pay for it even if the insurance company does not pay for it. So that was the referral network. Co-location's obviously the next step. So you actually go and share offices with possible referral sources. And I think Vince said this morning that he's looking at co-location opportunities with 45 different sites. That's truly integrating care, but at a level that again has fairly limited risk. I mean, co-location usually means that you're in their office or down the hall, and there can be a warm handoff where they can literally walk somebody down the hall and say, hey, here's Vince. He can talk to you, and if he can't see you right now, but you can be back here, and the assistant here can help schedule your appointment with him, and then I'll see you next week. And so all of that can be coordinated in one office. There are issues with it. You do have to clarify, clearly, as Jana talked about this morning, the differences between, your practice and the practice where you're co-located. You don't want the vicarious liability associated with it, so you want to make it very clear these are independent practices, and that's usually done through a sign or some type of little notice that says, we're associated with this practice, and independent of them, although we have a close working relationship. And again, one of the other things is when you're right there, you may have to provide services on a schedule and in a way that may be a little different than the way you were used to scheduling things on your own. But again, there's very limited risk. It's usually some type of a contract. Again, talking about, if there's going to be rent, what type of services, how many people you're going to have there, and maybe the times that you're going to be operating at that location. It may be every single day. It may only be certain hours of every day, or it may only be 1 day a week or 2 days a week, but at least then they know when you're going to be there and they can hand off for those specific times. An independent practice association goes a little bit further. IPAs are, on the healthcare side, the physician side, people actually used to call independent practices or physician associations. They also could be called an independent professional association. They usually are designed to take a group of independent, obviously is in the name, practices that are in a given geographic area to contract with managed care companies or to provide services to a specific health system, and it's usually fairly limited to what the purpose is. So, it could be a geographic area. I'm practice out of Chicago, so there could be the DuPage County Independent Practice Association, which is really designed to provide services throughout the collar counties of Chicago and contract with insurance companies and hospital systems, health systems in that area. It's very possible that psychologists could be asked to join independent practice associations with health systems that are trying to expand their behavioral health services, for the purposes of providing mental health services at the practice locations and the geographic area, the service area of that health system. Or to contract with the payers, the third-party payers who are providing, who need a network in that very specific geographic area. There's limited legal risk because it's a contractual relationship. So, you can join. We had a discussion this morning about the things that you look at in any type of contract like this. But, you look at the types of services, you look at compensation. I mean, it may be that you're going to be billing and collecting on your own anyway. There may be a billing and collection component for it. So as joining this, they may actually do some of your billing and collection for the services provided through the network. And for that, they'll want a particular fee, and all of that needs to be evaluated. But unlike the prior models, these practices, because there is joint negotiation with the payer, again has some clinical integration. Alan mentioned the 11 items that they look at, so there's probably going to be some type of credentialing, there's going to be quality measures, there's going to be some type of peer review. They could terminate you if you fail to meet these obligations. You're going to sign something that says that they can contract on your behalf if it's not the messenger model. And so again, it's a contract, but it's going to require maybe electronic health records, that you use their system, you provide them with information, and allow them to oversee the quality of your work. So again, it has a little more legal risk because you're now part of a network. So if something goes wrong in the network, and you're affiliated with it, you're a member of that. So if they have the wrong billing practices or something happens, there's a death by a member of somebody who participates in this, obviously that could get back to you. But again, you can join and you can terminate, so it's not a long-term, there shouldn't be a long-term consequences of having a contractual relationships with an entity like this. You see these frequently at major health systems across the country. But again, because you are independent when you join these, you do maintain your business autonomy. Let's see. You are contracting with different business entities. So you could be part of a network with your potential competitors. The management services organization is the organization that many people don't know about right now. It is a very versatile model. As I said, it's really not well known within psychology, but I work with management services organizations in just about every other type of profession. It's really taking some of the concepts that the IPA has and enhancing it on steroids. It provides a much broader range of services and programs for practice organizations. And so instead of being limited to one geographic area, the management services organizations can be multi-state, they can be national, in some cases they can even be international. I haven't heard anything yet about international yet from Shirley or Alan, but we'll worry about that later. Marketing under the same brand. It's similar like True Value hardware stores. I mean, True Value hardware stores are actually independent hardware stores that all join together to market and be managed by one entity. So, coming under a manager, contracting with a management services organization is one way to maintain this independence, but also have some type of a brand identity. As I mentioned, it goes beyond what the IPA does. It's actually real management services. So management services organizations frequently will put together policies and procedures on quality. They may have the electronic billing record. They frequently will provide all of the supplies and equipment for you through joint purchasing or group purchasing organizations so that you can actually benefit from some size in terms of acquisitions. The same on the equipment side of things. They may have standardization of equipment, and so you don't have to go through every single vendor or every single supply company to find out, is this the best? You've got a management company who's vetting all of that information and who can provide you with that expertise. And there are some people who, depending upon the management services organization, we even see them where they provide the space, the real estate. So they may have a location in an area, and they may have offices that are available for people to use. Let's see. It says the MSO can help you with the annoying aspects of practice that many practitioners hate. That would probably be the billing, the coding, the collection, and the interaction with all of the managed care and insurance companies. Because the amount of time, especially if you don't have a lot of administrative staff, trying to coordinate while you're practicing, but having to interact with all of the insurance companies and all the rest of it while they're, and on their schedule is not always possible. So that's kind of the MSO. The way that they can get compensated, again, is dependent, and here comes the sun. The way that they're compensated it depends upon the state. In some states that it can be a percentage of the revenues that are collected. That's not true of every single state. It could be a fixed fee. It could be a cost plus, where they actually take all the cost that they provided for you, and there's an administrative fee on top of it. It really depends upon the entity and how they're set up. But if you're approached by a management services organization, or you're looking at joining a management services organization, that's what you could expect in terms of compensation. And again, if you're trying to figure out, does this make sense for me? If you look at the amount of time that you spend on all of these administrative issues, and now you're going to have somebody else do that, and now you can take all of that time back and actually have it be productive and do the actual professional aspects of your profession, as opposed to having to deal with all of the HR and billing and collection and negotiating a lease with a realtor and all or the landlord. There's a cost benefit that you can weigh and see if it makes sense for you to participate in this type of an entity. And then finally, there is, again, this is not necessarily to maintain independence, but for comparison, you can always merge practices or become an employee. Merger is not really one of the alternatives that we're talking about, but again, it's a way of getting bigger. A merger, as opposed to these other alternative models that we're showing, is actually a legal combination of entities. I mean, so either one forms into the other one, or two or more entities form a brand new entity. Tax ID numbers can change. There's not only clinical integration, which is what we talked about from the antitrust standpoint for the MSO and the IPA, but there's actual financial integration. I mean, now everything's going into one bank account. I mean, the practices are truly integrated. There's no independence anymore. Obviously, this has the most legal risk, even though you could have a purchase agreement, that trying to unwind a merger is much, much more difficult than just terminating a contract with a management company or a co-location agreement. And it also, depending upon how the merger happens, whether it's a merger of assets or it's a merger of stock, you actually could assume some of the responsibilities, the liabilities of the previous entity. And so again, that's if you're considering a merger, you really want to do your due diligence, you want to do your homework, you want to do that investigation to make sure that you understand both the benefits and the liabilities of putting together a couple practices. And that's it.